Hello, this is about the new apprenticeship for doctor's assistants starting at East Sussex. This information is for managers, for people who are thinking about having doctor's assistants, and for the doctor's assistants themselves. So it's trying to cover a lot of things, so apologies. You can come back and ask anything in the future. So I'll rattle on. My name is Scarlett McNally. I'm an orthopaedic surgeon. We have no conflicts of interest. Health Education England kindly gave us a grant of £80,000 in 2017, and that covered the 5 doctor's assistants' salaries with on-cost and overtime and laptop and uniform for the first 6 months, and we're very grateful for that support. So the main thing the managers need to know is that someone who's doing an apprenticeship has to have 20% of time spent training, but some of that is within the workplace, learning and reflecting on work. It would be useful if you could each identify an educational supervisor, so a doctor or another senior clinician, who, just so the doctor's assistant has someone named they can go to for a query or to discuss an issue with. The really important thing is it allows staff to develop their role, feel valued, and I'm hoping it may help with staff retention. Because we started with 5 doctor's assistants in 2017 as the educational project, and then individual departments have recruited their own. We now have 13 with 4 posts in recruitment. We have had 11 leave, and although over 5 years one would expect some attrition, there's some people went on to do qualifications in health in another area, which is great as a stepping stone, but others it just didn't suit, and I'm hoping the apprenticeship will help because it's about developing and valuing the staff. And there are benefits of having an apprenticeship for the organisation and for the apprentices themselves. So the organisation gets well-trained staff, staff who want to stay, they want to do a great job, but they can challenge also, they can something within the workplace because they've got the knowledge of why things are being done. And also we may develop staff who can go into other roles locally, which would be amazing. For the apprentices themselves, it makes the job more interesting. It gives you a chance to challenge kind of nicely because everything's educational, and it puts you in a position to apply to other roles because it's a national qualification at level 3, so it then helps with, say, an application to a foundation degree or something. You always need to prove some qualifications for other roles. So when we started, we looked at other places that had done this kind of thing. So in Australia, they've published that having administrative staff improves doctors' productivity by 16% and reduces patient length of stay by 10%. In Southampton, they published in the Health Services Journal that having an admin assistant in the acute medical unit was very helpful. And in Brighton, they had a combined clinical and administrative kind of hybrid role on the surgical assessment unit. And Barbara Gosden, who was head of clinical education at East Sussex at the time, and I went to visit Brighton to see and borrowed a lot of ideas for them, for which we're grateful. So the practicalities. Here they are, the first 5 doctor's assistants. We had a lot of other people helping within the trust, helping devise what was needed in the education programme. So there's Professor Patel and Dr. Atham Nahas there, and other doctors, and the tall person at the back was helping with sorting out rotas. So you kind of need everybody to help in their way, and there's Barbara Gosden is in the photo with me as well there. And we have business cards so that if someone was challenged about what the role involved, they could say this is what we do, this is what we don't do, and it helped for the future. And also these are all the tasks that could be developed. Some do more or less than others in different departments. We spent a lot of time, Barbara and I, explaining what it isn't, because the physician associate role had been introduced at the same time, but that is very different. The physician associate requires a biomedical degree and then 2 years training, and they can work autonomously. They're allowed to examine patients, they can make decisions, they can make suggestions, they can discharge patients. It is a very different role, and it's also paid differently, and the doctor's assistant has a defined role. They develop what they want to do, such as getting the patient list up to date, or being able to do dementia screenings on people who haven't had them completed and so forth, but they aren't examining patients or finalising medical treatments. So we actually developed a brand new curriculum, and any curriculum is knowledge, skills and attitudes. So we worked out between us what was needed, and for example, the making every contact count training we fitted into the some of the fortnightly sessions after the induction, because that's about how to interact with patients without shaming them, about, you know, motivational interviewing, about stopping smoking and so forth. And so it's that kind of thing, treating each individual with respect, a lot of attitudes about how to use the trust values, and reducing instances of bullying in the trust and so forth. We could talk about at a different time. Communication also in the local press and to other staff. We did some research evaluation using tools developed with the University of Brighton. So this slide is about the time spent by doctors on the wards when they didn't have doctor's assistants, and they're basically spending 44% of their time writing discharge summaries or administration, and these are things that you don't need a medical degree necessarily to do. And when we've been running the project, we got a lot of qualitative and quantitative feedback. So this is the qualitative, the words, the ideas, and 95% of it was really positive, saying they were incredibly helpful, really good, useful for the patients, speeded up the patient flow, excellent attitudes. It was really lovely to get some of this feedback about how good the doctor's assistants were in their jobs. We did get some negative feedback, and we've used that to improve the programme. So there was a ward sister who wasn't sure what role they were playing, but identified there was a problem with filing of notes at weekends, so we improved that early Monday morning, how to collect information from the weekend and ensure it was fed forward into the daytime and that sort of thing. Dementia practitioner and a local GP helped with training to improve things so that things were done even better. And we had lots of quantitative results. We had logbooks, time motion studies, what the doctor's assistants were doing and how many multiple tasks they were doing every day. We had a ward with them and without them, and found that when they weren't there, there were 2 episodes where patients' transport was cancelled for going home because the paperwork hadn't been completed, and yet when they were there, things were much smoother, and 80% less chance of doctors requiring overtime on that day. And also on the ward rounds, they could start tasks. They could leave a ward round to go and resite a drip, for example, so someone could get their antibiotics. They could get the results up for the next patient. Ward rounds were quicker. They could scribe when required. A note on finances, because every business case requires thinking about the money. And we actually extended the project to show financial value, and this is on a background of the trust spending £1 million in a year on doctors at this level. And although a doctor's assistant can't replace a doctor, if there's going to be a known vacancy, they can you can plan for the doctors that are still there to work at the kind of top of their license and have someone help, and then you don't need to pay for a locum, and it's much more continuity. We did reduce exception reports, and there was speedier care and discharge, and better documentation, so that then our results look better, our reputation is better, and we're achieving the targets that the trust is required to do. And if you analyse each individual task, about 84% of them are about getting the decision or diagnosis earlier or care earlier for that patient. So it's incredibly valuable for the patients. You'll notice only 3% of these tasks are kind of labelled as saving time for the doctors, but actually all of them are things that either a doctor would do or wouldn't get done at all, and there aren't enough staff. So all of this is incredibly valuable. Just to make a point about the Agenda for Change pay bands, the doctor's assistant role has been analysed as being a band 3 role for the level of responsibility, and this is very different from the practitioner roles that tend to be 6, 7, 8 or so forth. Doctors have a different salary range, which ranges from band 3 sadly up to band 9. And the trust has a risk register of things that might potentially go wrong, and there are some that have no alternative plan because there aren't the people to recruit. With recognition for the role, we won an award. I'm very proud of this Skills for Health Award for workforce development, because it wasn't about saving time or being more efficient, it was about actually developing the staff. Finalist in the HSJ Awards and runner-up in the BMJ Award for clinical leadership, but that was more about the processing, improving patient flow, really. I've been requested the job description by various other places, and I've been to speak at a number of these, and we acknowledge Brighton and Southampton as places we borrowed ideas from. And one place I went to speak, they'd already appointed one doctor's assistant, and they said that before they had that, they had a band 6 flow coordinator, but all that person could do was nag the doctors to write their discharge letters, and it was much better to have someone who could draft a letter and then have that signed off later. We were quoted as a case study in the GMC report, Caring for Doctors, Caring for Patients, about improving doctors' working lives on the wards. We wrote it up in Health Management magazine, and we wrote up the evaluation in the BMJ Leader. And actually, it's quite a difficult role, the doctor's assistant role. You need complete clarity of the role and the task list so that things don't slip and people are asked to do more than they're expected to do. It does need good clinical leadership, and doctors are quite maverick, so it needs people to understand the medical model. It needs communication and education, and I think this is where we've translated a lot of this education to be mapped into the apprenticeship. Having the experience as a healthcare assistant means that people are aware of hierarchies, aware of pathways, aware of what ought to happen, and also just fit in to the culture. You know, for relative faints, for example, they know what to do because they've been in that situation. And we want challenges to be seen as educational and for discussion rather than a barrier. But it is quite a difficult transition. It needs a line manager who's not a doctor to sort out the mandatory training, the leave, and all the aspects of employment that actually doctors aren't so good at getting completely right. These are some of the doctor's assistants from 2021 with the Trust Chief Executive, and in the back row there's also Dawn Urquhart, Director in Human Resources, and Barbara Gosden again, who's leading the apprenticeship work in the Trust. And to talk about the apprenticeship, there's the apprenticeships are at different levels, and this will be a it's a level 3 apprenticeship, which is equivalent to A levels, and so it counts an advanced apprenticeship, and there are obviously different levels of apprenticeship. It is the senior healthcare support worker apprenticeship, which is nationally recognised. There's actually very few roles like this that combine administrative and basic clinical skills. Very few roles at band 3 that are clinical, but it could be a stepping stone for future education. And we've combined with an education provider called Dynamic that is providing the apprenticeship package. And these are their slides. Obviously, it's built on an agreement with the employer, with the apprentice, and with the training provider. So there's onboarding at the start, and one of the good things is this is roll on, roll off throughout the year. It's not the academic terms. A lot of it is delivered online, and there's an initial assessment to see how much knowledge people have to begin with, which might actually shorten the amount of time they need to spend doing the apprenticeship. So the application programme has eligibility checks. It's just fill out a form, and you can fill it out putting to be confirmed if the educational supervisor hadn't been selected, for example. And they start with an induction and information. The care certificate and English and maths are required. And before coming to an assessment, there'll be mock assessments and evidence of completing all the assignments and elements. And then at the end, there's an endpoint assessment with an observation in practice, multiple choice exam, and looking at a reflective journal. And a certificate at the end that's nationally recognised. So most of it will be the learning as one goes along. It takes between 12 and 18 months, depending on how much one has done to begin with. And it's really anything that's new learning. So developing a skill or observing something and reflecting upon it. And off-the-job training counts as all those other things. So the written assignments, but also shadowing, going to a different department, having coaching sessions, and shadowing colleagues. The progress will be monitored continuously, and each apprentice will be assigned a coach, which is a one-to-one person to keep a track on progress and to discuss things with, which I think is a fantastic part of this educational provider's offer. Each apprentice is required to complete the work and attend training sessions and communicate with their coach. Local information, for us, the trust requires people to have functional skills, that's maths and English at GCSE level, grade A to C or level 4 to 9 or equivalent, and the care certificate. As I said, each person will get a coach, and the department would ideally help find a supervisor who's a doctor or senior clinician to be able to discuss things with that particularly relate to that workplace. And there is a small training grant that's just a few £100s that has been allocated for each apprentice to help with some other costs that might be involved in being an apprentice. So in summary, doctor's assistants are a fantastic part of the workforce. There is safe and high quality care. It's also cost effective and has immediate impact for the organisation. But the role does need to be very clear, and it needs support from medics and separately line management. And what I'm hoping is the apprenticeship will really pick up the educational angle, so that all staff are valued for their development, give peer support, and to help the individual do their job really well now, but also develop what they might want to do academically in the future. So do feel free to contact me or the apprenticeship team with any questions. Thank you very much.